Chronic coronary disease and stable angina form one of the most foundational, most heavily tested topics in all of cardiovascular medicine. And this masterclass is going to give you a complete clinical blueprint for diagnosis, management, and exam mastery. Whether you're preparing for USMLE, MRCP, PLAB, AMC, or your MBBS finals, this single condition teaches you the core physiological principle that underlies nearly every other ischemic heart disease topic you'll ever encounter: the balance between myocardial oxygen supply and demand. We'll walk through the modern terminology shift that's reshaping how this disease is classified, the precise mechanism driving anginal pain, the rise of a newly recognized non-obstructive ischemic entity, the full risk factor profile, the exact clinical criteria used to classify chest pain, the step-by-step diagnostic pathway, and the three-pillar management architecture, including a major 2023 guideline update on beta blockers that catches many learners off guard. By the end of this masterclass, you'll have a single, elegant framework connecting every concept in chronic coronary disease, exactly the kind of high-yield understanding that distinguishes a well-prepared exam candidate. For years, this condition was simply called stable ischemic heart disease, or SIHD, a static label implying a fixed, unchanging condition. But that old paradigm has been formally retired. Under the 2023 AHA, ACC, ACCP, ASPC, NLA, and PCNA guideline, the preferred term is now chronic coronary disease, or CCD. This isn't just a cosmetic rename, it represents a genuine conceptual shift. CCD is now defined as a heterogeneous spectrum encompassing both obstructive and non-obstructive coronary artery disease, patients with a prior myocardial infarction or revascularization, and the full range of chronic anginal syndromes, regardless of the precise underlying mechanism. Rather than viewing coronary disease as a single stable snapshot in time, CCD frames it as a lifelong continuum of risk and care that a patient moves through, from initial diagnosis through ongoing secondary prevention for the rest of their life. Here's the exam pearl worth memorizing. Chronic coronary disease is now functionally synonymous with stable ischemic heart disease in modern question banks. So if you see either term in a clinical vignette, you should immediately recognize them as referring to the exact same patient population and disease spectrum. At the heart of stable angina lies one elegant mechanism: a fixed supply confronting a variable demand. On the supply side, an atherosclerotic plaque creates a fixed narrowing within the coronary artery, and critically, this narrowing comes with impaired coronary flow reserve, meaning the vessel has lost much of its normal capacity for maximal dilation. On the demand side, three variables drive myocardial oxygen consumption: heart rate, blood pressure, and contractility, and all three of them are dynamic, rising and falling with the patient's activity and emotional state. At rest, this system maintains balance, since baseline demand sits comfortably below the limited but still adequate supply, and the patient remains entirely asymptomatic. But with exertion or emotional stress, sympathetic activation causes demand to spike sharply, and the stenosed vessel simply cannot increase flow proportionally to match it. The result is that demand crosses what's called the ischemic threshold, the precise point at which oxygen need exceeds oxygen delivery, and this triggers the characteristic anginal pain. Resting brings demand back down below the available supply, restoring balance, and explaining exactly why rest reliably relieves the pain within minutes. Classic obstructive coronary artery disease involves a focal atherosclerotic plaque causing a fixed, visible narrowing within a large epicardial artery, exactly what you'd expect to see clearly on a coronary angiogram. But there's an increasingly important and increasingly tested alternative mechanism worth understanding: INOCA, which stands for ischemia with non-obstructive coronary arteries. In INOCA, the patient experiences genuine objective ischemia, confirmed through stress testing, yet their coronary angiogram looks completely clean, with no significant epicardial blockage to explain the symptoms. The underlying mechanism here isn't a focal plaque at all. Instead, it's driven by coronary microvascular dysfunction, an abnormality within the heart's smallest vessels, invisible to standard angiography, or by epicardial vasospasm, a transient constriction of the artery itself. What makes this concept genuinely high yield for current exams is that INOCA is now explicitly recognized within the 2023 Chronic Coronary Disease Guideline framework as a legitimate cause of classic anginal symptoms, even in the setting of a completely clean angiogram. This matters clinically because a normal angiogram should never be used to entirely dismiss a patient's anginal symptoms as non-cardiac in origin. Understanding who develops chronic coronary disease starts with the classic atherosclerotic risk profile, divided into modifiable and non-modifiable categories. The modifiable risk factors, the ones we can actually intervene on, include hypertension, hyperlipidemia or dyslipidemia, diabetes mellitus, cigarette smoking, obesity combined with physical inactivity, and an unhealthy diet. These represent the primary targets of lifestyle modification and pharmacologic prevention throughout a patient's care. The non-modifiable risk factors include advancing age, male sex, and a family history of premature coronary heart disease. Here's an important clinical nuance worth remembering. While male sex is traditionally listed as a risk factor, the risk gap between men and women narrows substantially after menopause, reflecting the loss of estrogen's protective cardiovascular effects. And for family history, the exact diagnostic criteria matter for exam purposes. Premature family history is specifically defined as onset of coronary disease before age 55 in a male first-degree relative or before age 65 in a female first-degree relative. Knowing this precise cutoff, rather than a vague sense of young, is exactly the kind of detail that separates a correct answer from an incorrect one on a board exam. Recognizing classic anginal chest discomfort requires knowing 4 specific clinical dimensions. The quality of the pain is typically described as pressure, heaviness, tightness, squeezing, or a burning sensation, and this is an important red flag distinction. Pain that is sharp, stabbing, or pleuritic in character should point you away from cardiac ischemia and toward an alternative, non-cardiac diagnosis. The duration is classically 1 to 5 minutes, only rarely extending beyond 15 minutes. Provocation follows a reproducible pattern. The pain is triggered by a consistent level of exertion or emotional stress, the same threshold each time. And relief comes reliably within minutes of rest or sublingual nitroglycerin administration. Beyond classic chest pain, anginal equivalents are critically important to recognize. Dyspnea, unexplained fatigue, nausea, and diaphoresis can all substitute for typical chest discomfort. This atypical presentation pattern is especially highly tested in elderly patients, women, and diabetics, populations where autonomic neuropathy and altered pain perception frequently mean classic chest pain simply never occurs, even with significant underlying ischemia. Classifying chest pain into typical, atypical, or non-anginal categories relies on a simple 3-criteria framework. The 3 criteria are substernal chest discomfort with the characteristic quality and duration we just described, provocation by exertion or emotional stress, and reliable relief by rest or nitroglycerin within minutes. Chest pain meeting all 3 criteria is classified as typical or definite angina. Chest pain meeting exactly 2 of these 3 criteria is classified as atypical or probable angina. And chest pain meeting only 0 or 1 criterion is classified as non-anginal chest pain, making cardiac ischemia a much less likely explanation. It's worth noting an important nuance for advanced learners. While older pretest probability tables built around this 3 criteria framework have been somewhat de-emphasized in recent guidelines in favor of more holistic, individualized risk assessment incorporating additional clinical factors, this fundamental 3 criteria framework itself remains a genuinely useful and still foundational tool for initial clinical triage. Every chest pain evaluation, regardless of how sophisticated the subsequent workup becomes, still starts with asking these same 3 basic questions about quality, provocation, and relief. One of the single most consistently tested clinical triage decisions in all of medicine is distinguishing stable angina from acute coronary syndrome, and the distinction comes down almost entirely to the patient's history. Stable angina, sitting within the chronic coronary disease spectrum, is predictable and reproducible. It has an exertional onset, a duration of 1 to 5 minutes, and it resolves promptly with rest or nitroglycerin. Acute coronary syndrome, by sharp contrast, is unpredictable, either entirely new or distinctly worsening in what's called a crescendo pattern. Critically, ACS pain classically occurs at rest, lasts longer, often exceeding 15 to 20 minutes, and does not reliably resolve with rest alone. Recognizing this history-based distinction immediately and correctly is one of the most heavily tested triage decisions across every major clinical examination, because the downstream management pathways diverge dramatically. Stable angina permits outpatient workup and optimization, while suspected ACS demands immediate emergency evaluation, serial troponins, and urgent risk stratification. Getting this single distinction right, simply by listening carefully to how the patient describes their pain, is often the most important diagnostic step in the entire encounter. The diagnostic pathway for suspected stable angina follows a clear stepwise sequence. Step 1 is a thorough history, physical examination, and basic laboratory testing, including a lipid panel and HbA1c, while also ruling out anemia or thyroid dysfunction as alternative explanations for symptoms. Step 2 is a resting 12-lead ECG, and here's a crucial point worth remembering. This is frequently normal, and a normal resting ECG does not exclude underlying coronary artery disease. From there, the pathway branches based on whether the baseline ECG is normal. If it is, and the patient is able to exercise, an exercise treadmill ECG is performed, looking for ST depression, symptom reproduction, or an abnormal blood pressure response during exertion. If the patient cannot exercise, pharmacologic stress imaging is substituted instead. If the baseline ECG is abnormal, for example showing a left bundle branch block, a paced rhythm, or baseline ST changes that would obscure interpretation, stress imaging, using either echocardiography or nuclear myocardial perfusion imaging, is used directly, regardless of exercise capacity. An important guideline rule underlies this entire pathway. Clinicians should generally intensify medical therapy first when possible, reserving additional testing for new, persistent, or escalating symptoms where the result would genuinely change management. When direct anatomical visualization of the coronary arteries is needed, two major options exist, each with a distinct role. Coronary CT angiography, or CCTA, provides direct, non-invasive visualization of the coronary anatomy, and per the 2021 AHA and ACC chest pain guideline, it has become an increasingly prominent first-line test for patients presenting with new onset or persistent chest pain who fall into the low to intermediate risk category. Its major advantage is that it avoids the risks associated with an invasive procedure while still providing detailed anatomical information about plaque burden and stenosis severity. Invasive coronary angiography, or ICA, remains the gold standard anatomical test, providing the most definitive, highest resolution view of coronary anatomy available. It's generally reserved for higher risk patients, those with high-risk findings on non-invasive testing that warrant further investigation, or for preoperative planning immediately before a planned revascularization procedure. The clinical decision between these two pathways essentially comes down to risk stratification. Lower risk, diagnostically uncertain patients are well served by CCTA, while higher risk patients, or those already being considered for intervention, generally proceed directly to invasive angiography.
Optimal chronic coronary disease outcomes rest on three structural pillars, each addressing a distinct therapeutic goal. Pillar 1 is lifestyle modification, aimed at risk reduction and improving functional capacity. Pillar 2 is standard medical therapy for prognosis, focused on secondary prevention, preventing future myocardial infarction and stroke, and ultimately extending the patient's life. Pillar 3 is anti-ischemic therapy, focused specifically on acute symptom relief and chronic prevention of recurrent anginal episodes.
These three pillars work together, but it's essential to understand that they are not interchangeable. A patient can be entirely free of anginal symptoms on excellent anti-ischemic therapy while still carrying substantial cardiovascular risk if their prognostic secondary prevention therapy is inadequate. Conversely, a patient may be optimally protected from future heart attacks through statins and antiplatelet therapy, yet still suffer significant quality of life limiting angina if their anti-ischemic regimen isn't properly optimized. Recognizing that symptom control and mortality reduction require genuinely separate, deliberately layered treatment strategies is exactly the conceptual framework that distinguishes sophisticated clinical reasoning from simply memorizing a drug list. Pillar 1, lifestyle modification, includes smoking cessation, adoption of a Mediterranean dietary pattern specifically favored for its strong cardiovascular outcome evidence, structured physical activity combined with weight management, and referral to a formal cardiac rehabilitation program. Pillar 2, prognostic therapy, begins with antiplatelet therapy, typically low-dose aspirin, with clopidogrel substituted in patients who are aspirin allergic. High-intensity statin therapy is Class 1 recommended for essentially all chronic coronary disease patients. And here's the exam pearl worth memorizing. If LDL cholesterol remains at or above 70 milligrams per deciliter despite maximally tolerated statin therapy, a non-statin agent like ezetimibe or a PCSK9 inhibitor should be added. ACE inhibitors or ARBs are recommended specifically when the patient has comorbid hypertension, diabetes, chronic kidney disease, or reduced left ventricular ejection fraction. Now, here's a critical 2023 guideline update that frequently surprises learners trained on older material. Routine, indefinite beta blocker use purely for prognostic benefit is no longer recommended beyond 1 year post-myocardial infarction unless the patient has an ejection fraction of 50% or less, or another independent indication, such as arrhythmia or hypertension. Anti-ischemic therapy maps onto 4 distinct drug classes, each working through a different physiological mechanism. Nitrates are first line for acute symptom relief, working through venodilation, which decreases preload, reduces left ventricular wall stress, and consequently lowers myocardial oxygen demand almost immediately. Beta blockers are first line for chronic prevention of anginal episodes, decreasing heart rate and contractility, directly lowering oxygen demand both at rest and, critically, blunting the rise in demand that occurs with exertion. Calcium channel blockers offer 2 distinct mechanistic flavors. The non-dihydropyridines, verapamil and diltiazem, lower heart rate and contractility similarly to beta blockers, making them a reasonable alternative when beta blockers are contraindicated, while the dihydropyridines, such as amlodipine, work predominantly through arterial vasodilation, reducing afterload instead. Ranolazine deserves special mention as a uniquely valuable add-on option. It's a late sodium current inhibitor that reduces angina frequency without lowering heart rate or blood pressure, making it an ideal choice specifically for patients whose hypotension or bradycardia limits further use of the other 3 drug classes. For patients with stable, moderate to severe ischemia and a preserved ejection fraction, the management approach has undergone a genuine paradigm shift, and this is one of the most important pieces of trial knowledge for postgraduate level exams. The old reflex, Path A, was that documented objective ischemia should prompt routine early revascularization. But the landmark ischemia trial demonstrated that this approach did not reduce the rate of death or myocardial infarction when compared directly with optimal medical therapy alone. This finding fundamentally reshaped guideline recommendations. The current 2023 guideline standard, Path B, instead directs clinicians to optimize medical therapy first whenever objective ischemia is identified in this population. Revascularization, whether through PCI or CABG, is now reserved specifically for 2 scenarios: refractory symptoms that persist despite genuinely optimal medical therapy, or specific high-risk anatomical findings, such as significant left main coronary artery disease or extensive multivessel disease combined with reduced ejection fraction, where revascularization confers an independent prognostic benefit. The essential takeaway, and a frequently tested exam point, is this: in stable chronic coronary disease with preserved ejection fraction, stents improve quality of life and symptoms, not lifespan. Let's bring everything together into one master synthesis. Every intervention in chronic coronary disease ultimately manipulates just one of two variables, supply or demand. Stress testing works by provoking the equation, deliberately and artificially spiking demand in a controlled setting specifically to push the patient across the ischemic threshold for diagnostic purposes. Lowering demand is achieved pharmacologically through beta blockers, calcium channel blockers, and nitrates, each forcefully pulling heart rate, blood pressure, or preload away from that same threshold, relieving symptoms. Increasing supply is achieved mechanically through PCI or CABG, physically removing the fixed stenosis itself to restore the artery's normal flow reserve. This framework explains every diagnostic test and every treatment decision we've covered throughout this entire masterclass, from the initial history and physical, through stress testing and advanced imaging, to the 3 pillars of management and the ischemia trial's redefinition of when revascularization actually helps. The final exam pearl is this. Cardiology is not about memorizing endless lists of drugs and tests. It's about understanding and manipulating a single, elegant physiological equation. Master the threshold, and you master the disease.